Hello, everyone. Welcome to IFC webinars. And today, what are we going to discuss? Personal protective equipment, how to buy, how to choose, how to address shortages, which also happen from time to time, especially during COVID pandemic. We realized that there is such an issue as the shortage of personal protective equipment. And of course, COVID-specific personal protective equipment. We already received multiple questions regarding which is the best mask, which is the best respirator, which is the global trend now. So let's discuss today and let's ask our experts. And our first speaker today is Julia Rodríguez, Knowledge Management and Epidemiology Director from CEDIMAT Hospital, Dominican Republic. Julia, the floor is yours.
Hi, everybody. Well, while I share my screen, I'm going to have a couple of disclaimers and thank yous to do. First, to all of the team and IFC for the invitation. Thank you very much. We've been working together the last year, and it's very good news for us that you consider our practices to be good enough to be shared with the world. So we really appreciate it, and we thank you for that at CEDIMAT. Also, two other disclaimers. I had to do remote connection today, so I will have a couple of a little bit of background noise, and maybe a child can come later. So I apologize in advance, but I think we have everything covered and it should be okay. Second disclaimer is that this presentation is based a lot on our experience. So you won't be seeing a lot of references in it. Our practices are all based on CDC guidelines and WHO recommendations. We'll be happy to share any of those afterwards via email if you like. However, in this presentation itself, we will share the experience, okay? So let's begin. What's behind the mask? Procuring and using personal protective equipment effectively. This is going to be our agenda. Let me see if I can, wait, this is not letting me. Okay. So first, I am in the Dominican Republic, so I would like to give some context of the country and what we have or what we had before the pandemic in our country and the experience of our hospital. Then a little bit of context of our hospital itself, at the medical center where I work, the experience pre-pandemic, what we had to challenge and the strategies that we used during the pandemic, and what happened later and what did we learn from it. Okay, so it's a very simple presentation, but I hope it can bring you a lot of knowledge that you can use in your daily life. So, Dominican Republic. We are a small island in the Caribbean. We share the island with Haiti, and we are the second largest nation in the Caribbean. Our island is called Hispaniola, and we are between Puerto Rico and Cuba. Our country has a population of around 11 million inhabitants, and we have a tropical climate. Okay, so our everyday it's very unexpected. I can have very rainy days and then beautiful sunshine in our white sand, blue water beaches. But we also have mountains, and we have a lot of history and culture, okay? People here enjoy music and all the fusion of European and African and Taino traditions and costumes that contributed to the development of our society itself at the beginning of the discovery of the New World in 1492. Tourism became a strong industry in our country. So for transmittable diseases, it has a very high impact in our economy. So when the pandemic came, it was a very hard situation for us, and it would hurt really much our economy. Our hospital. Well, this is CEDIMAT. It comes from Diagnostic Medical Center of Advanced Medicine. It's what the acronym means. It was founded in 1999 in March by this young man that you see in the picture is Dr. Juan Manuel Taveras. He is a radiologist from one of a small town in Dominican Republic that's called Moca. Juan Manuel Taveras went to Boston, Massachusetts, and became a very high impact scientist, humanitarian, and later on, he became the father of neuroradiology worldwide. He had this vision of creating a nonprofit hospital in our country that will provide access to everybody for this high-tech medicine. Also, he thought it should be accessible to everyone. It didn't matter the economical status of people, and that we should focus on research and teaching. So we used to have only this part of the center when he opened it in '99. Unfortunately, due to his profession, he was at high risk of cancer, and 3 to 4 years later after opening, he passed away, and he couldn't see the growth of the hospital. So first we grew to hospitalization wards here, and then we opened the cardiovascular center that has all of that high tech that he was dreaming about. Okay. Our vision is to be leaders in diagnostic medical services and promote preventional medicine locally and internationally, and to promote medical education and scientific research. Okay. So our pre-pandemic experience with the personal protective equipment. I give you the context of our country because our climate and tourism are two of the biggest risk factors and influencers on the diseases that we see. So with all of the rainy seasons that goes from May to November, we have endemic dengue fever. We also have leptospirosis and tuberculosis endemic to the country. And we have a lot of experience also with HIV and other viral infections. After the earthquake in Haiti, we had an outbreak of cholera, and it's been around since then, even though in very low levels, but we have a lot of experience in that matter. So all of this are very different than what we had to face with the COVID-19 pandemic. They are different vectors, different rates of transmission, and it was very unexpected, just like it was for the rest of the world. But we tried to prepare for a pandemic in 2014. With the outbreak of Ebola around the world, our national authorities developed teams and strategies for clinical management. They tried to prepare different hospitals and how would we react if we got cases in the Dominican Republic. With that came some good things and some bad things. Good things is that we learned about PPE a little bit. We got some stock. It was a long time ago, but we learned about it and how to handle it. There was a lot of teaching throughout the nation on how to use the hazmats and how to create isolation areas in hospitals that were not meant to have any. And for our hospital itself, I put this group of people here. I don't know if you can see the mouse on the picture, but that white hair man that you see was the head of the National Commission of the Ebola team, okay, in 2014. But today he's the medical director at CEDIMAT. So we had the most trained person in transmittable diseases and the one that knew all the strategy directing our own center. Okay, we have become a very big center. We're a national reference center today. And having someone with that experience was really good. But also the bad thing of Ebola is that even though it was good for us not having cases, which is sadly not the situation in other countries, but we didn't have cases. So it was kind of like the story of the piggies and the wolf. And people thought that COVID-19 was not going to come in some ways. We were all a little bit of ready for it, but we thought it was not going to affect us, really. And that happened throughout the whole system. Now, pre-pandemic, we had different access to PPE, and there was attitudes and collaboration. It depended a lot on the personnel. We had masks, gloves, and gowns. They were just another way. We never had any shortage of these materials. And of course, nurses are the ones that are in charge of infection prevention and all of the international patient safety guidelines and policies in our hospital. So they were always seen as the police of infection control. And they were after people, there still are. And I think that's also the situation in different hospitals. On hand washing and respecting isolation and visitors in the areas and all of that. Bioanalysts, on the other hand, are very structured in a different way. They have accreditation for the ESO and from a Mexican accreditation entity. So they are very used to following protocols, but they are very isolated in their own work. So it was a very, they worked as an island. Then we had doctors that has for today are the ones that handle all of the scientific information and the clinical direction of all cases, but they wouldn't mind about nurses or bioanalysts either. And then all of the concierge and cleaning personnel that would be very scared of managing anything that had to do with transmittable diseases. So we had difficulties in collaboration, and even though patient safety was a priority, protecting ourselves and our medical personnel was not. This is the isolation, some of the things that we use when we have a patient that needs different types of isolation, droplets, contact, aerosol, and they are posted in the door of the ICU rooms or in the wards, because we have independent rooms in our hospital. We have 180 beds in our hospital and 4 different ICU units. When COVID-19 came, we had different challenges and strategies. First of all, was that teamwork that never really clicked for infection prevention and control. Also, we had to change the entire distribution of our hospital so we could ensure non-COVID areas and COVID areas, and that patients will not be afraid of coming to seek for help in the hospital for non-COVID diseases, because they would see hazmats and all of this equipment that will have like a strong effect on them. So we created an ER2, a consultation 2, and an entire floor just for COVID that will connect, let's say, just behind the scenes through back elevators. And when we had to use the normal transportation areas, we would do it after 6 p.m. where there was no patient, no patients around. It was like the slow area hours in the hospital. So we also had to avoid panic, and just like the rest of the world and like general population, there was panic, misinformation, and difficulty in accessibility for the PPE. Good enough for us, N95, which is the mask that is recommended and that has been from day one our best ally in this, was not, we didn't really had a shortage of it. Hazmat, on the other hand, they were very difficult, and there were lenses available, but no face shields, and gloves. We always had a lot of those. With the difference on how we would organize the hospital, we had nurses on 24-hour calls, and then they would come back 6 to 7 days later, and if they presented any symptoms, then they wouldn't come. So we have shortage of personnel because we have 35 nurses only for COVID-19 areas. Doctors were on 1-week calls, and residents had to do 7-hour shifts that with the hazmats was very complicated to do. We measure exposure time, and we kept track of every single patient with sign of COVID, tested every other patient that was hospitalized, just to make sure that we kept all of the of clean areas, right? Separated areas. Now, regarding to PPE, which is our main focus today, N95 had to be given 1 per day, because even though we didn't have any shortage, we knew that getting them was going to be difficult, and we calculated the dates on when we would get the next shipment, and it was like a month away of what we had. So we prayed that it worked, and instead of reusing them and changing them, we used 1 N95 per person that would come into the COVID-19 area. They had to make sure not to get it dirty, not to get contaminated. Some of them would use alcohol to clean them and then dry them in the sun. Some had the UV lights that at some point they said it would work to decontaminate them. And luckily it didn't go any worse than that. However, we did prepare to shortage of N95, considering washing them and reusing them. But once we rewash them for tryouts, they would lose this like the hairy thing on cotton. So we thought if we got into shortage, we would use a cloth mask, and then we would use the N95, but it never really had to come to that. Now, hazmats were a different story. That was terrible. They were too heavy, too hot, and not enough for everybody. So we had to reuse them. And for reusing them, what we did is we washed them. We dunked them in water with chloride, and then dunked them in a second tank with water with chloride. Then we would hand them and wash them with a hose with water, and let them dry to the sun for around 12 to 18 hours. But then it was never enough for them to dry because the material was too heavy. So sometimes they had to use it wet. Nobody liked them. Then a second group of hazmats was donated, and they were too light. They would break. They were not the correct size. And in the end, our personnel just decided not to use it because they would say, well, this transmits through here, respiration and your hands. So we'll just wash our hands and change our clothes and we should be fine. And that's what we did. And actually we didn't have high rates of transmission in the wards. Actually, transmission came higher when people were resting in their homes and they would get together with families, but that's a different story. Lenses for intubation and aspiration were terrible because with the mask, they would get blurry. And they would also cut our personnel in the nose. So we had people bleeding from different like lenses over their reading glasses. And it was a mess, and we didn't have face shields available. So this is not us, this picture, but I couldn't find a picture of that box. But we did have a box just like that to aspirate and try to intubate the patients. But it was also terrible. It was very difficult for manipulation and vision, and it was bad for the patient, and it would not protect the personnel. So we stopped that. And we just went with our N95 and the reading glasses. When face shields came available, which were like the best solution for that, then everybody had lost fear for COVID-19 and nobody wanted to use it. They don't use it today. We treat all of the PPE as biological hazard, and they go into the red bags, and we treat it just like biological hazard all times. And when they need to be rewashed, they are in the red bags and they go to a different cycle in the cleaning area. Yes, I went through that already. We had no visitors in the areas. Patients had to wear masks all the time. We went for open ventilation in the room, so open windows and open doors. And once panic started to decrease and we understood that we didn't need all the equipments, that it was just droplet transmission, and we needed to isolate, wear masks, and wash our hands, and more scientific evidence came available, then we were fine. But at first it was very scary, like for the rest of the world. Today we have face shields available, and they are in the protocol of the COVID-19 areas, but being honest to you, nobody wants to wear them. Everybody still uses their mask and some surgical gowns when they have to do any procedures to the patients, and gloves, evidently. Patients now prefer the closed ventilation in the room and their AC. As long as everybody's wearing a mask, they should be fine, and it has been okay. Still no visitors. Lessons from COVID-19 is that misinformation and panic are really not allies to anybody, not in society, not inside of the healthcare facilities. We need to trust evidence and our experience. We knew how droplet transmission worked, and everything said that it was droplet transmission, but we were just not trusting it because all of the misinformation that we had around the world. it would have been a lot easier in the beginning. Teamwork and consideration for other safety made hard work very easier. And our personnel got in touch with the humanitarian side of medicine, going from all the difficulties that personnel had to go through while trying to wear all of this outfits to be able to provide healthcare, seeing patients alone in the wards and in the ICUs. It was a very humbling situation for us. So just to give you thanks for your time. This is just our radiology and diagnostics team. I couldn't find pictures of everybody in the hospital. We are around 500 only doctors, and then we some nurses and technicians. But having the patient first and making sure that we do everything for their safety is best, and having them leave the words with that smile is the goal. So thank you very much. I'll be staying here for questions. Sorry about all the noise.
Thanks a lot, Julia. By the way, I don't hear any noise. Wonderful presentation. Thanks a lot for sharing lessons learned and CEDIMAT's experience, because we believe this knowledge sharing is the most precious part when hospitals can exchange the lessons learned and how they address various challenges, COVID-19 obviously being one of them. By the way, we already have questions arriving for you, Julia, so you can get ready meanwhile, and we'll discuss them during our question and answer session towards the end of our webinar, as always, after all the speakers finish with their presentations. So now I want to introduce our second speaker today. That's Dr. Nigel Croft, a lead author of the Technical Benchmarking Guide on Personal Protective Equipment. Nigel, over to you.
Thank you very much. And I always feel a little bit like an imposter when I'm speaking to a healthcare audience. My PhD from 40 years ago is actually in material science. So I'm not a medical doctor, but I do know quite a bit about materials and the way that they're used in various aspects. I'd like to start off just by emphasizing that IFC is a large organization. And one facet of IFC is in the area of PPE, PPE manufacturing. So we're looking at this from a slightly different angle. In the same way that if you Google the IFC healthcare webinars, if you Google IFC PPE webinars, you will find a number of, well, this is the fifth that we've done in this series on aimed primarily at manufacturers, but also in this case, looking at guidance to purchasers. The second thing I thought it would be appropriate to mention is that in addition to making sense of PPE, the regulations and standards, I should probably have changed that to trying to make sense, because there are a lot of complexities in this whole question of the standards that are applied and how to go about purchasing quality PPEs within your organization. So what I'm going to present today is basically around this technical benchmarking guide on COVID-19 related PPE. It does apply to other, and it will apply to other pandemics. This was work, as I said, done under the IFC PPE advisory, carried out by British Standards Institute in the UK, and with support from the Foreign Commonwealth and Development Office of the UK government. Two main objectives. First, and foremost, I should say, is to help manufacturers and conformity assessment bodies, such as laboratories, inspection bodies, certification bodies, in supplier countries to understand the various regulatory and other requirements for PPEs within their key potential markets. In other words, the purchasing countries, those who are seeking to buy PPE. And I think it's relevant, as Julia said, at the beginning of the pandemic, there was, I'll not say panic, but the whole purchasing ethos had to be adapted to get something. And I think there was a philosophy, and it wasn't wrong, that anything is better than nothing under those very, very critical circumstances. So that was the focus of the technical benchmarking guide, but equally, we want to use the results of the technical benchmarking guide to help purchasers and users, those of you who are taking part in today's webinar, to understand the main similarities and differences, sometimes very subtle differences, between your own requirements for PPEs in your home market and those of other markets, to identify possible opportunities for alignment. And as I think Julia mentioned, the sort of standard that you used in Dominican Republic, N95, a US standard with regulatory implications in the US, governed by NIOSH, for example. Now, this technical benchmarking guide is quite a comprehensive document. It's 300 pages long, so don't be put off by it. What I want to do today is to give you a little summary of the main topics that are covered. These are the products that we cover. No big surprises there. And we looked at 13 different markets around the world, and these are mentioned here. We did have criteria for deciding on these markets that we would look at, but I don't really have time to go into that right now. But you will see that the main markets, US, EU, Australia, we have examples from Brazil. I'm actually in Rio de Janeiro at the moment. We have examples from Malaysia, India, Jordan, and others. The first thing I think we need to understand when we're looking at purchasing is the difference between standards and regulations. A standard such as in Europe, EN 149, which is the standard for respirators, or in the US, the 42 CFR Part 84 N95 standards. Are they voluntary or are they mandatory? Well, the Technical Barriers to Trade Agreement of the WTO, which governs most international trade, makes a very specific distinction between the two. In principle, standards issued by organizations such as ISO, International Organization for Standardization, such as CEN in Europe, such as ANSI or ASTM in the US, they are voluntary, in inverted commas. Technical regulations, on the other hand, are mandatory. So if you want to sell your products, or you are based in the EU wanting to buy PPE, it's not negotiable. Your products that you are buying have to be demonstrably conforming to the PPE regulations in Europe. And in some cases, the medical device regulations, and we'll talk about that complexity in a minute. Good regulatory practice is generally that regulations, the mandatory part, based wherever possible on voluntary standards using international or regional standards as a basis. If a product, a PPE or a medical device can be demonstrated to meet those voluntary standards, there is what we call a presumption of conformity with the relevant regulations. So if there are no regulations in your country regarding the import of certain kinds of PPE, then in principle, you can buy whatever you want. Obviously, there is a responsibility to protect the citizens of your country and to protect the environment. But in terms of standards, you have some flexibility as to what you actually order. So keep that in mind. Technical regulations are mandatory. Standards are voluntary. Conformance with standards can be considered to confer presumption of conformity to the technical regulations. We have a further complication. When we talk about regulations, what are we talking about? Are we talking about PPE regulations or are we talking about medical device regulations? And in some markets, these are very different. You will need to look at your own particular market if you are purchasing PPE for medical use. The generally accepted definition of PPE is something that protects the wearer. So as Julia was saying, you know, initial concern was always about patient safety and infection control. But then with the COVID situation, hey, you know, we need to look after our doctors and nurses and frontline workers, and we have to protect them. And that is where PPE comes in. So masks, of course, protect the wearer, eye protection, gloves, clothing, and so on. They are all covered by this guide. But in general, PPE regulations also cover a wide range of products that are not relevant to COVID-19. You know, things like hard hats for use on construction sites, general work gloves, ear protectors, safety boots, and so on. On the other side of the equation, we've got medical devices, which again is a vast array of products, some of which are not relevant to the PPE used in a pandemic. Pacemakers, stents, breast implants, and so on. And those regulations also typically cover a wide range of products. So some COVID-related PPEs have potential dual use. Things like masks, gloves, and clothing might be classified as personal protective equipment. They might be classified as medical device, or they may be classified as both, depending on the specific application and also depending on the claims that are made for them by the manufacturer. So, for example, the Therapeutic Goods Administration in Australia is very, very clear. If there is any implication on packaging or the product itself that product is aimed at providing infection control for patients, then it is classified as medical device. If there is any implication that it's for use as personal protective equipment, then it is PPE. And there are implications in terms of the quality requirements, in terms of the conformity assessment requirements, and so on, which purchasers need to be aware of. So some of the key challenges that are faced both by manufacturers and purchasers. Those technical regulations differ from one country to another, one region to another. We already mentioned about the differentiation between PPE and medical devices. The voluntary standards, you know, we're talking here about standards like ISO or EN in Europe, or ASNZ standards in Australia, or ABNT standards in Brazil, and so on. Those standards may be national adoptions of international or regional standards, which is the aim. Because if they are national adoptions, then the standard that's used in Brazil, if that's a national adoption of an ISO standard, then that should be the same as the national adoption of the same ISO standard in Vietnam or in Malaysia, which facilitates the comparison and facilitates the whole purchasing process. The problem is that those standards sometimes are standalone national standards, and I'll talk about that in a minute. We often use different approaches, different product categories, you know, broad product categories for masks, for example, or very specific, material-specific product categories, maybe for gloves. We have the different applicable versions of regional and international standards. We have the latest international version, maybe that ISO's just published a new version of its standard for gloves in 2022, but that standard has not yet been adopted as your national standard. Equally, it may have been adopted as your national standard, but that is not the version that is yet referred to in the technical regulations in your country. So unfortunately, these are complexities that we have to deal with. And then there is the question of conformity assessment. How can you have confidence that your supplier is actually meeting the standards that they claim for their products? That involves inspection test methodologies. It involves sometimes product certification, quality management system certification. in general to ISO 9001, or if it comes under medical devices, then we have to deal with the ISO 13485 quality management system for medical devices. So these are some of the complexities that collectively we have to look at. So the approach we've taken in the benchmarking guide is to understand those complexities, not sort of try to be oversimplistic, but understand the complexities and then simplify the concepts. We've benchmarked using US and EU standards, which I think are the ones that most people are familiar with. We've used color coding to emphasize similarities and differences, but with the possibility to drill down for more granularity and more detail as needed. So a high-level overview, and I certainly don't intend to go into this in any detail, but this will give you a flavor for what's in the guide, and we've given you the download. The guide is downloadable free of charge. So what we see in some countries, for example, Jordan, we've put color code yellow here for most of these products, which means that Jordan standards are based on or similar to the European standard. If we cut this another way, what we see is that, for example, surgical gloves, there is a preponderance of green here in the different countries. And so for surgical gloves, there is a tendency for those to be based on or similar to an ISO standard. We also cover in the guide other topics that we feel are relevant for purchasers. Specific guidance for purchases of medical PPE. Caveat emptor, let the buyer beware. You need to be very, very clear that you specify exactly what it is that you want to purchase. What standards, what regulations, and allow the supplier or the potential supplier to understand and to be able to provide a product that meets your needs and expectations. Second, how to assess claims of conformity. A supplier may come along with a very fancy certificate. In my experience, I may be being a little bit unfair, but the fancier the certificate, the more seals it has on it, the more stamps and the more colorful, then the less confidence I have in that. So the medical PPE arena, you need to check to make sure that that PPE that you are purchasing is actually certified, it's being tested by what we call an accredited conformity assessment provider. Now, that word accreditation within the conformity assessment arena is slightly different from hospital accreditation. Accreditation means that conformity assessment provider, whether it's an inspection agency or a laboratory or a certification body, has been evaluated and found to comply with the requirements of the relevant conformity assessment standard, which covers things like competence, impartiality, decision-making processes, criteria, and so on. And those accreditations typically are conducted by national accreditation bodies. In India, for example, I see we have Anil Jari with us on the call. Anil was CEO of the Indian accreditation body, NABCB. We have organizations like UCAS in the UK, United Kingdom Accreditation Service. So in principle, if you see a laboratory test result with a UCAS logo on it, that will probably also have a logo of the International Laboratory Accreditation Collaboration, which says that you can trust in the results of this certificate. Whether it's in Brazil or Argentina or Ethiopia or wherever, if that accreditation body is a member of the International Laboratory Accreditation Collaboration, you can trust that certification. Likewise for certification bodies, product certification, management system certification, there is the International Accreditation Forum, which also provides mutual recognition. I think Julia mentioned about the question of fit and the design of PPE. IFC has done a lot of work for looking at PPE for women. The WHO, in one of our previous webinars, made the comment, and I think it's extremely relevant. If medical PPE is not fit for women, it's not fit for the majority of the health workforce. But we're not just talking about masks. Julia mentioned about, heavy, uncomfortable biohazard full body equipment. That has to be taken into consideration when you are purchasing. Things like gender, ethnicity of your workforce. There may be certain ethnic people, for example, who use beards. It may be that they need a special fit for their PPE. We cover as well sustainability, environmental issues. Should we be looking at full life, reusable PPE, or should we be going for the easy option, in inverted commas, of disposable PPE? Of course, that has huge environmental impacts. And so we need to look at the durability, use, reuse, and recyclability of PPE. And within the IFC PPE project, we're currently working with the Indian manufacturers and the Indian government to look at potentially developing a new laundry standard for reusable PPE. And then, as I mentioned already, there's different kinds of approaches to conformity assessment and accreditation and so on. I just mentioned down here, there is actually an ISO guidance document, not specifically for PPE, for medical PPE, but in general, this guidance on sustainable procurement. So those of you who are involved in procurement, I would strongly recommend you to take a look at that. I'm going to skip over this slide because I think I've already talked a little bit about the different forms of conformity assessment. The final slide, basically, I want to comment practical tips and guidance for those who are involved in purchasing. I'll go through this very quickly. We will be making the slides available to you, and we will probably be putting this out as a very simple 3 or 4 page guide for purchasers, elaborating on each of these steps. Number one, make sure you know very clearly what it is you want to order. Make sure you liaise with the users of the PPE. Consider inclusivity, sustainability issues. Is it going to be reusable or is it going to be single use? Make sure you're familiar with the applicable standards and regulations for use and import into your country. If you're a private hospital, you can't just say, oh, just send us according to your national specification in India. If there are technical regulations in your country that only products that meet those technical regulations can be placed on the market in your country. So you need to make sure that you are familiar with those regulations. Identify and evaluate potential suppliers, including manufacturers, not only the importers and the distributors. Communicate all the relevant requirements to your potential supplier in any request for quotation. Include, for example, the grade, the size, any other information that needs to be specified, if it's reusable, etc. Review proposals, not only based on price. Now, that depends on individual government purchasing policies, but if it has to be placed with the lowest bidder, make sure you put all the technical requirements back here in the request for quotation. But look at it holistically. Look at it on the life cycle. Use a risk-based approach. What's the level of confidence you have in that supplier? Have you purchased from them before? Are they a traditional supplier? Have they any quality management system certifications? To determine the extent of the oversight needed. Now, that will also depend on the size of the order that you're going to place with them and your purchasing power, if you like, as to whether you're going to put third-party inspectors, pre-shipment inspections, and so on. That's probably not going to be realistic for small orders, but for huge ongoing orders, that might be appropriate. Place the order, include all the relevant information, reserve the right to carry out incoming inspection. So when you receive the order, make sure somebody is actually inspecting it. That doesn't necessarily mean repeating all the testing. If the testing has been done in an accredited recognized laboratory, you may not need to do that. But conduct some kind of incoming inspection. It can be by sampling. Look at the marks of conformity. Check that the marks of conformity are credible and can be related back to an accredited conformity assessment bodies. Look at test reports, any accompanying certificates, etc. In case of doubt, and depending on the size of the order, you may want to do independent testing of a random sample at an accredited laboratory in your country. Do that. Make sure you do that, because you need to have confidence in the level of protection that you are giving to your workers. Finally, seek feedback from the users and update your supplier information. Those of you who are familiar with the Plan, Do, Check, Act cycle will realize how important this is. Get feedback from the users. You know, Julia mentioned about some of the, I think the eye protection was making people's noses bleed where it was rubbing on the eye protection. That feedback is important for the next time you make another order for that particular PPE. This is the dream. We're still a long way off. This is sometimes it's called the ISO dream, sometimes it's called the accreditation body dream. One standard, one test, one conformity assessment procedure, product certification or whatever, accepted everywhere. Wouldn't that be wonderful? Wouldn't that simplify everybody's lives? And one of the inputs into moving this agenda forward is the technical benchmarking guide that we've come up with, and we will be making recommendations, for example, to the International Organization for Standardization, to the various regulators around the world, to try to drive this forward, which will drive out an awful lot of waste and an awful lot of unnecessary cost in everybody's supply chain. So thank you very much for your attention. That was a very brief run through the technical benchmarking guide, and obviously I'll be happy to answer questions at the end. Thank you.
Thank you so much, Nigel. Lots of useful information and lots of useful tips, I'm sure, including the 12-step guide. And we're looking forward to the full guide version coming soon. So now we have actually not quite the usual speaker. We have a panel consisting of 3 experts, and we will be discussing questions that partially were already touched upon today by Nigel and by Julia, because we realize that still there is a lot of misunderstanding in the area of PPE, how to really use safely, how to procure, etc. So let's have a thorough discussion with our experts now, and then we will have, as usual, our question and answer session. Thanks a lot for sending your questions. We already received a lot, so it's going to be interesting, I think. So our panel discussion includes now 3 experts. So number 1 is Daniel Tugume from Nakasero Hospital, Uganda. Expert number 2 is Dr. Mohammed Garout, clinical epidemiologist from Saudi Arabia. And number 3 expert is Manuel Giralda, lab expert from Canada. Welcome. Thanks a lot for joining. And the first question will be for Daniel, actually. So Julia already touched a little bit the question of shortage of PPE, which I think is obviously a nightmare for every hospital. So did you have any experience of shortage of PPE in Nakasero Hospital? And what advice would you give how to address such shortages, how to prepare yourself to uninterrupted supply? Thanks a lot, Daniel.
Thank you very much. I will begin with the experience we had just before COVID. We had this company that was supplying sanitizers and other PPE, and they had come to teach us about infection control. And they were actually giving us free PPE, and we were not even interested. Then just shortly after that, we had the pandemic. And we were looking for them, and this time they were not interested because everyone was quoting them, the prices went up abruptly, and that was our first test of the shortage, because the pandemic was ill prepared. However, we were able to run around, source PPEs from our sister colleagues, other hospitals that we cooperate with, and we were able to restock and manage for the time being as we prepared now to make large orders. So that shock helped us to regroup and now reorganize on how to manage the PPE supplies that we had, as well as the ones that were going to come in from the orders that we made. So the key lessons that we learned there in managing shortages: one, don't rely on the supplier only. You need to know the supplier of the supplier, because the secondary supplier determines whether the primary supplier will get the PPE and give it to you. So we have to go beyond the suppliers that we are seeing to know the cause of the shortage, especially from the supplier side. Then we had to start monitoring consumption trends. Previously, we used not to care. We had gloves, we had masks in the store, so it was business as usual. But now we started being strict. We started finding out which departments actually require the PPE more than others, which departments use more PPE compared to others, and then how much they consume on a daily basis, on a weekly basis, on a monthly basis, so that our procurement would be targeted to the consumption and also leave room for some contingency, so that in case we have some overusage somewhere as a result of an emergency, we still don't get stuck. Then that to improve our database of vendors. Previously, we would have just one vendor. So we started now getting alternative. For each type of PPE, we would have to have at least 3 or 4 vendors. But if you call vendor 1 and they don't have, you call vendor 2, vendor 3. By the time you get vendor 4, at least you get the supply that you want. Then our relationship with the suppliers also improved. We started prioritizing them. So in the past, the first priority would be pharmaceuticals. Pay these guys first. The guy for PPE would remain unpaid, because really they were not that important. But now they quickly moved up to the priority list. So we had to make sure we pay them quickly. Otherwise, they will supply someone else and you will not get your supply that you want. We had to enter into long-term contract arrangements, get them locked in, get commitments. We started communicating with them more constantly. So the relationship management between us and them really improved, because now they have become one of our key suppliers. And then we also had to look at options of local manufacturers, because of the restrictions on travel, the bans. Even when you place an order and even pay in advance, if it was coming out of the country, it was going to be delayed. You'd still get shortages. So now we started looking locally, because also the government had started licensing some local manufacturers. So we had to subject, of course, their product first to some quality checks to see if they meet the standards. We had to test them with the users to see if they are acceptable. And then the local manufacturers now became an alternative for cases where we did not have supplies coming in from imports, especially like from countries like Kenya, where the travel restrictions were very high. And also, even when there were not restrictions, the trucks used to be stopped at the border, because the truck drivers had to be checked for COVID, then they had to be quarantined. So you would have a delay at least of not less than 2 weeks. So you would have to find alternatives locally. Then we had to educate users on how to use PPE. The main reason there was to avoid wastage, so that someone doesn't use PPE that they don't need to use. You don't find a cashier putting on hazmat suit because they are very scared of COVID. You have to reserve those for the people who are in the COVID unit. The types of mask change. At the beginning, we used to give everyone an N95 mask. Then we had to downgrade to KN95 for the administrative staff. For example, like if you're in HR, you don't need the N95. If you maybe at the reception, but the doctor will need the N95. So started now educating people. You don't need this kind of PPE. Much scared of the disease. This kind of PPE is effective in protecting you. So we didn't have now the shortages of the critical PPE that were needed to take care of the COVID patients because of the education that we gave to our staff, and also not to waste, like someone doesn't need to put on 4 gloves. 1 glove is effective enough. So for cases where we would find someone with about 3-4 masks, we tell them it's not helping at all. Just 1 mask is sufficient. So that kind of knowledge helped reduce on the overusage and the wastage, and it cut down on the shortages as well. Then we also taught people about the disposal management to prevent premature disposal, because you open a glove, you put in once before you even touch 1 or 2 patients, you're already replacing it. So also that also helped us to prevent shortages as well. And then we had to start classifying zones, the risk zones, where the PPE is required, where the PPE is not required, so that the appropriate PPE is used in the appropriate place depending on the risk. So that also helped us now to start being better and managing our stock and preventing shortages as well. Then, of course, we started limiting users. We reduced populations in places where PPE was required. So we brought in those elements of people working from home, especially if they didn't need to come to the hospital. Now, then the go part, we started limiting the elective operations that would require PPE. The patients that had become better, that did not require to stay in the hospital in areas where PPE was required, started to be discharged. We started pushing more for telemedicine, where you don't have now to interact with the patient. You can see them across the screen. Then there's no need for PPE. And then we also started the selective other mechanisms like sanitization, social distance, things that don't require PPE but prevent infection and cross infection. And then we shifted now from disposable to reusable. So when you have something that is reusable, then you can use it more often than what you have to use now and then dispose of. So it cut down again on the shortage as well. So and when we got enough stock, we started controlling the distribution. So instead of everyone going and picking, we started giving the PPE to the supervisors. And the supervisor would ask you why you need the PPE so that you don't waste it, so that people don't start carrying and taking home, others selling it off. So we started controlling the issuing of PPE, which helped us also to reduce on the shortages as well. So, but as Nagasaki Hospital, we are part of the group. So we have about 3 other hospitals that we collaborate with. So we also came up with a system where we would make group orders. So the 3 of us make 1 order, and then the PPE comes and we share. So that way we don't have shortages. And also, if your colleague has more stock and you're running out, they could give you, and then when you purchase yours, you give them back. So those are some of the different arrangements we made to manage the shortage. And of course, in terms of finances, we had to rethink our budgets because what we had planned before for the PPE was not enough. So we had to go back to the drawing board and up the budget on PPE, of course, with some adjustments on what we view the patient to cover the cost as well. So that's what I can share on that question.
Thanks a lot, Daniel. These, I think, wonderful tips. Yeah, great tips. I think we're having some connection issues because I can hear my echo. Can you hear me okay?
I can hear you. Yes, I can.
Okay, yeah, wonderful. So basically, do not rely on one supplier. That's a very good piece of advice. Obviously, you need to use the worst case scenario. This is something I can add from my part on this, thinking what can potentially go wrong, as Daniel was saying, giving examples. Yeah, there might be some restrictions, there might be some suppliers problems based on your experience before, based on your observations. Use plan B, C, D, etc. With your supply chain. Definitely you need to plan well, and also get the statistical data on how many masks are used, how many gloves are used in every department, considering all the specifics. Yes, it's a lot of internal work, but it's definitely worth it because planning gives you also an opportunity to plan your stock properly. By the way, for those who were having connection issues, please join our community of practice because these are all very useful tips. We will be posting them in our Facebook group, and you will have a chance to revise it all and to see the points that you probably missed because of poor connection. We're sorry about that. So then also, of course, not to waste medical protective means. This is also great advice. Obviously, this is connected with planning, but also with staff training and education. I agree with Daniel. Sometimes staff just put on some personal protective equipment and then just throw it away without even touching the patient. So correct use of PPE is also an important part. So I will pause here in order not to waste time. We see all your questions arriving. Thanks a lot. And our next question on this panel will be for Mohammed. As an expert in epidemiology, so lots of speakers today mentioned reuse of PPE. Are there any PPE that can be reused, and which is the safe way of doing it? What are the key principles that we need to bear in mind? Mohammed, you're welcome.
Hi everyone, thank you, Julia, for the question. Basically, when we're talking about PPE, we're talking about usually we're talking about single-use PPE. So single-use means that it has they have to be used for once and to be discarded correctly. However, since the COVID-19 pandemic has started, almost all countries across the globe have faced the issue of the shortage of supply of PPE, as mentioned by our colleagues today. And there should be there had been an alternative or crisis management strategy to overcome this risky issue in order to continue providing the required medical services by all healthcare workers in a safely way. Some of the single-use PPE, as per some published guidelines in different countries, were advised to or can be reused according to the published guidelines. However, no practice without risks. But having this shortage issue had forced everyone to think of alternatives. So when we say, for example, N95 masks can, with some guidelines, can be reused, can be decontaminated or reprocessed again so for several times. But let me just mention that there is no agreed upon guidelines by recognizable references like CDC, WHO, European CDC, and so on. So we need to bear in mind that the risk assessment in such situations is the cornerstone of whatever process that we in a country to be implemented. So risk assessment is important, and evaluation, supervision, continuous monitoring of the agreed upon practice should be continuously implemented to evaluate the pros and cons of the new approach, which is actually nothing connected to the normal infection prevention and control measures or practices that we have been practicing before the COVID-19 pandemic. N95 masks, as I mentioned, in some guidelines, they can be reused, or there is what is called extended use, and the extended use is more preferable than the reuse of the PPE or single-use PPE. Some studies we have to realize that we don't have very much reliable studies that had been conducted so far to agree or have to start with what exactly the right guidelines or accurate guidelines that we need to follow with this regard. However, some countries, for example, like in Brazil, United States, they approved the reuse and extended use of N95 masks. On the other hand, Canada, as far as I know, they approve only the extended use, similar to France and Mexico and New Zealand. So in Saudi Arabia, for instance, we were lucky to have our own experience few years before the pandemic, when we were hit by the epidemic of MERS-CoV and in 2014. So this experience had developed some lessons that we learned from, and among that few lessons that we need to be prepared at all times in expecting the unexpected. And it's just few years later, and we had been affected with similar to any other countries in the globe with COVID-19 pandemic. So what we basically did at the beginning of the pandemic, early 2020, we at national level, we had different crisis management plan. So for instance, I'll give you just a quick example that we requested as a new regulations, all healthcare facilities providing medical services, we requested them to have monthly checks of the stocks of PPE, okay, plus 30% extra. Okay, this was mandated. and all hospitals were checked regularly by the Ministry of Health in Saudi Arabia, as well as the national accreditation body, which is SIBAHI, the Saudi Central Board for Healthcare Accreditation, and on-site checks were conducted. Okay, to ensure that all healthcare facilities are compliant with the new regulation. Among the we actually encouraged the hospitals to develop their own internal risk assessment. So the distribution of the PPE in hospitals should not be equal. So they know the areas where hot areas or areas where they are expecting to have more patients or more exposure for healthcare workers. So this activity or practice was closely monitored over the last 2 years. So when there was a situation where shortage of PPE is expected, okay, we had the hospitals, they already have the chance to respond proactively in appropriate time. Another issue is we have in Saudi Arabia what is called National Unified Procurement Company, which is a governmental company where all healthcare facilities, okay, they can go back and share with them with the company which is under the supervision of the Ministry of Health. Any healthcare facility can share the constraints or difficulties in procurement issues related to PPE or in other medical issues. So the support comes from there. So the Saudi Arabian experience, actually, we did have some difficult times, okay, but with the proper crisis management, we managed to safely go through the pandemic issues, shortage of PPE supply, and so on. Thank you.
Thank you so much, Mohammed. Very useful information, lots of useful tips. And also, I wanted to draw your attention to Nigel's point in the chat. Definitely, what is important is to move to the risk-based approach. So prevention becomes more important, especially based on the lessons learned from the COVID pandemic. Now we all know how to be prepared. And Mohammed mentioned 30% increase in stock. This also might be a good solution. Be prepared just in case. So now specific question, lab. In each hospital, staff are every day exposed to body fluids and other samples. Manuel, what are the key principles in the lab regarding the PPE? That's question number one. And question number two, how to make staff actually follow the requirements, because often we find them just neglecting these principles, thinking I'm doing it every day, I'm going to be fine without PPE. So over to you, please.
Well, thank you, Julia. Thanks for the invite to this important presentation. And I'll share with you my experience after working many years in lab medicine, in pathology, in different capacities as a lab scientist, doing testing myself in different disciplines, hematology, biochemistry, and pathology, and transfusion medicine. And then later on as a manager, director of a lab in Ontario, in Canada, teaching hospital. So going to your questions, number one is that usually people think that the usual requirements for labs are normally are gloves, mask. Sometimes you have, obviously you have to wear your lab coat, and you have to have your shoes closed. But there's more than that. And depending on where you work in the lab medicine department or in pathology, you gotta work, or you have to have extra precautions to avoid contamination and injuries. Number one, we gotta remember that the lab is, like Julia mentioned today, Julia Rodríguez from CEDIMAT well mentioned it, that the lab sometimes it's an isolated area in a hospital, and it's heavily regulated. So for many years, the labs have worked under, under these regulations, whether it's a national accreditation body, international accreditation, or following international standards such as ISO. And that's why the people in the lab tend to follow very easy procedures and policies, and they have written all this documentation so the team can work in a standard way. And nevertheless, even with all this regulation, still things happen. There was a good study a few years ago, published where they found that many injuries happening in the lab, such as needle prick, or even splashes when you are handling fluids and blood. Even with all these regulations, things happen, so we gotta keep that in mind. And the lab is a highly contagious area, and only people authorized to be able to have access to the lab. So when the number one, when I do visits, when I do assessments, when I work in my labs, I want to make sure that the lab is well identified by visitors and by patients, and we want to make sure that they have a sign in front of the main entrance of the lab where you have a sign that says only authorized people can access the lab. And the second thing that you want to remember everybody, you want to remind everybody, is that you gotta wear PPE practices as per hospital or lab policy. And there's sometimes people add another sign, but those are the two main signs that you want to put in front of your door. The other thing that I want to remind you is that the people at the audience is that there's something called universal precautions. And these are well described on international guidelines such as WHO, such as CLSI, or in Canada, CSA, or UK, or Australia. There are many international guidelines that are published, and you can access to them at any time. You can strengthen your lab areas. For those who are listening, lab managers or lab scientists who are listening to this topic, and even anybody in the hospital, it's always well to have these guidelines. Number one, we are not supposed to eat and drink in the lab, right? And I've seen this even in very tight environments where people mainly work, when they work shift work, evenings or nights, they tend to bring their food, or they tend to have some food, goodies in their drawers and things like that. Washing your hands frequently or before exiting, that's another big important rule that we must follow. I've seen people that do not wear gloves when they are testing, or even when they are doing phlebotomy procedures. Recapping needles, that's another big no-no that we have to avoid. I've seen hospitals and labs where people are wearing sandals, and obviously there's a huge risk of splashes or having even a glass penetrating your heels or the back. And sometimes people just close their shoes, the toes, but they don't close their back. The standard is to wear shoes that close your heel and also your toes. And then another one that I've seen frequently, and people don't really pay attention to, is that having long hair and tie. If you have long hair, you gotta tie that to the back, because if you lean on a bench, you can contaminate your hair with chemicals, with fluids. And even there are cases, there was a case where someone was, I think it was a female, I can't remember the place, but long hair was caught up in a centrifuge when she was, there was spinning the centrifuge. Remove your lab coat before exiting the lab. That's very important. People forget this. And what they do is they bring that lab coat outside where it's already contaminated. And they sometimes even go to a cafeteria, they go to a lounge, and there is a risk of contamination. Now more so important to do this with COVID. And another one that not too many people know is to pay attention to your electronic devices. The use of cell phone within the lab should be very carefully considered, and there should be a policy within the lab across the hospital as far as using electronic devices within the lab premises, even sometimes in other locations as well within the hospital. Now, there are some lab-specific recommendations and things that people don't follow. For instance, a lack of eye protection. If you are liquiding specimens, or if you are pouring urine or fluids into another container, you gotta protect your eyes of splashes or even aerosols that could contaminate your eyes and your mucosas. Lack of gloves when working with formalin. I've seen this mainly in pathology, even respirators. There must be worn in pathology if you are using large quantity of formalin. And lastly, if you are planting bacteria in microbiology, you must do this ideally in a biosafety cabinet, because you can have any bacteria that could be, contagious, a highly contagious bacteria such as Brucella, and you don't know, that could go obviously very bad if you acquire that. And in pathology, I've seen myself, even in highly regulated environments, that people had cuts and injuries when they're doing microtomy or where they're doing the grossing of the specimens. So these are things that happen. There are multiple studies where they said, okay, there are injuries that happen throughout the lab, even with highly regulation. So what happened is people don't report these injuries, and we say, no, yeah, it's okay. So reporting and investigating injuries, accidents, and incidents in the lab is very important, because we learn from it. Going to your question, Julia, the second question is about how do we prevent? Well, number one is we gotta have we have to have strong policies and procedures. We must develop a biosafety manual with all those policies and procedures included, that we incorporate international guidelines, international best practice from recognized organizations such as I mentioned already, WHO, CLSI, or you can use ISO 1590, which is specific for lab safety. And then you also need to train your staff. You need to educate your people on an ongoing basis. That's key. On an annual basis, there should be some mandatory education to your lab team in terms of PPE, regular wearing and policies, and some basic information as far as universal precautions that I mentioned earlier. The other thing that I do, in my experience, that works really good is to have safety audits. So safety audits are those things that you do on an ongoing basis when you have your lab manager or your safety lead. By the way, it's important that for large organizations, more than 10, 15 people, or even more than that, I will suggest strongly to designate a safety leader, somebody within the lab team who will be doing those safety audits, not once a year, on a monthly basis, where we will review if the team is wearing properly PPE on your daily basis. You have to do that as well as a manager in the management team or the safety people. Even everybody should pay attention to everybody, because safety is for everybody. It's not only a management, it's not only a hospital, it's everybody. We need to live in a safe environment. So we must help each other on this. And then the last part is the reporting, like I mentioned it. And one last point is to keep in mind what Mohammed mentioned is the risk management and risk assessment. If you, once you identify there is a new safety or new tests or something that causes risk into your employees, you must do a risk assessment to identify prevention and mitigation strategies. I think that I hope I summarized your question, Julia, so far.
Thanks a lot, Manuel. That was brilliant. By the way, we are running out of time. As always, thanks a lot. We receive a lot of questions from you. And as always, unfortunately, we will not be able to address all of them during our webinar because our time is limited. Thanks a lot to all our experts because they type their answers to you. You can check it in question and answer section. Already Nigel and Daniel, they responded to part of the questions. So thanks a lot once again. And now we actually take several questions from our audience. So now we finish our regulated panel discussion and we invite all the experts who did the presentations today to participate. Actually, we have a lot of debate, a lot of discussion, both in chat and in question and answer, again, regarding the use of PPE. So I think let's take this question as the first one and maybe give an opportunity to our experts to express their opinion. So what would be our guidance regarding the reuse of PPE? Is it easier just to buy reusable PPE and reuse them and thus avoid shortage? Or is it safer to buy single-use but plan it? So what would be the strategy for a hospital if they are a little bit lost without guidance on this? Nigel, do you want to start?
Yeah, if I can start with that. I mean, I'll start with it from a sort of generic quality approach. And within the sort of quality management arena, I should say I was chair of the ISO committee that wrote the ISO 9001 standard. So I'm a little bit biased in that. But we use what we call risk-based thinking, which is a kind of fuzzy concept. It's not as rigorous as risk management. It doesn't necessarily mean you have to have a risk register, but it's what my dear departed grandfather used to say to me when I was young. The problem with common sense is that it's not always very common. And so what do we mean by that? I mean, everybody in an organization should be aware of what are the potential hazards, what is my exposure to those hazards, what's the potential consequence of those hazards. So rather than just applying something in a blanket way throughout a hospital, throughout the administrative and so on, there has to be that risk-based thinking and a dialogue. And there is, in fact, the ISO 45001 standard for health and safety management systems. Manuel was saying about doing audits, safety audits. I would strongly commend, everyone to take a look at that standard. As far as buying reusable PPE or single use, I mean, at the beginning of the pandemic, you would take what you could get. I mean, that was very much the order of the day. I think as we move forward and look at the lessons learned in the context of sustainability, in the context of what we're doing to our planet, we definitely have to move towards both purchasers and manufacturers alike coming up with reusable, useful, comfortable, financially viable PPE and the associated methodologies with them, the laundry and the testing, to make sure that they continue to provide that protection throughout their life cycle.
Yeah, thanks a lot, Nigel. And the next question is a little bit connected to the previous one, and something that Julia and Nigel already touched a little bit during their presentations. It's the satisfaction of staff, how to choose the best PPE, not from the point of view of use, single use or multi-use, but how to make staff satisfied, because we all know, and I know myself, staff complain a lot. I don't like these masks, I can't breathe. I'm sweating in those gowns. These gloves, I have skin irritation. These are too thin, these are too thick. So, and Mohammed mentioned also certain principles. So how to combine it all into procuring the best PPE that satisfies everyone? Nigel, do you want to take this question as well, or Mohammed maybe? I see everyone is keeping silent. Who wants to be a volunteer?
I can comment on that.
Yes, please.
Of course, first you have to define the acceptable quality levels. Much as they complain, you have to have acceptable quality levels. Is the PPE fit for purpose? What is the degree of excellence in terms of performance? Then secondly, you look at the certification. So it has to meet the standards, the quality standards, the certifications that are required by the body. And then the appropriateness of the zone in which the staff is operating. So the PPE, you should give appropriate PPE depending on the zone in which the staff is operating in terms of risk and contamination as well. And then, of course, feedback is very important. You don't ignore the feedback. If the staff tells you when I put my hand through this glove, it just goes right through. You don't force them to use the glove again because they will get contaminated again. So you have to listen, but also have the standards. Then you should have your quality control team that can look at the feedback that the staff have given, that can look at the samples that have been provided by the supplier, and also give an objective opinion, because sometimes people get biased, they get subjective, they get compromised by the pharmaceutical companies. So you find someone is complaining and recommending a brand because they've been compromised. So you need to have your quality standards team to look at this PPE vis-a-vis the feedback that you're getting from the users, and then you come to an objective assessment on what is actually appropriate for use. Thank you.
Thanks a lot, Daniel. Wonderful, very structured response. Also, Manuel wants to say something. I think to add something on this.
Well, thanks, Daniel. I think that was great. But adding to that, I will stress the fact that working in safe conditions is key for employees. So training and education is key. It's a great principle that we must keep in mind. And the second thing is that in many organizations, they offer options and solutions to employees who have allergies or who have issues with a specific PPE requirements. They might be able to help you to find a solution. So connect with HR, with occupational health, and hopefully I'll be able to identify an extra different options for you. But it's very important that we keep a safe environment to our employees.
Yeah, Nigel also has a hand. Thanks a lot, Manuel.
Yeah, I think there are two things here. One is, if we think about quality as being meeting specifications, that's one thing. But the other perspective of quality is fitness for purpose. And I think part of the problem, and I'm going to raise a topic now that I know is very dear to WHO and IFC's hearts, inclusivity, gender neutrality, and so on. Many of the standards have been written traditionally by, middle-aged white men, without necessarily thinking about the needs and expectations of other ethnicities, of gender. The comfort, it's not just about the size, it's about the comfort. It's about, women healthcare workers who are going through their menstrual cycle and maybe suffering from hot flashes and during the menopause and so on. That was brought out very amply by April Baller at one of our from WHO. So I think we have to get away from just thinking about quality. Well, it meets the specifications and it's been demonstrated to meet the specification. Are the specifications themselves actually right? And then the second part, to Manuel's point, I totally agree. It comes back to risk. It comes back to risk. And what is the risk of using PPE? Well, if I'm, conducting some delicate task and I have to wear this PPE over my eyes and it fogs, then that's going to be worse. It could have negative outcomes. So it's always going to be a balance. Use or don't use. I think in the COVID perspective, it's use, let's opt on the side of caution, but be cognizant of the potential negative effects associated with that PPE. Maybe heat exhaustion, if people are working, and they're working in very hot coveralls, and they start fainting in the middle of the of a procedure, then that is not good either. So risk-based thinking and fitness for purpose.
Wonderful, Nigel. Thanks a lot. Mohammed, you have a hand.
Yeah, I just want to add to the great things that have been mentioned by our colleagues here, that, healthcare workers cannot protect patients if they cannot protect themselves. So highlighting what I believe could be underestimated number, it was said that almost 140,000 healthcare workers have passed away during the pandemic, which I believe could be underestimated number. Okay, so this could be largely part of part of it, of this death due to misuse, shortage of PPE, and so on. So we need to consider the psychological part, and as Daniel mentioned, yes, the feedback is important. Okay, but we need to not to think of from the bigger picture only. We need to go down to at individual level. So, for example, if there is a group of staff who raised this issue, okay, they simply, according to the risk assessment for them, okay, we can just keep them away from that service, reallocate them somewhere else where the exposure might be less or severe or so, and until we find, for example, different supply chains for that with PPE that might not cause any harm to them, and so on. Thank you.
Thank you very much, Mohammed. That's valuable, very valuable point. I think we're running out of time, and let's take just one very last question. We discussed the use of single use, of multi-use PPE, disposal of PPE. What is the key principle? What do we need to remember? How to safely dispose PPE? Because Daniel raised the question, sometimes PPE didn't touch the patient, didn't touch any body fluids. So what principles should we have in mind being a hospital, especially if the regulations do not give clear guidance? Not in every country they do give clear guidance. So I think maybe Manuel can start, and then also maybe Mohammed can give his input to these questions, considering the specifics.
I believe that PPE used during pandemic or dealing with COVID-19 patients, they are under the medical regulated items. So they are infectious, and they should every healthcare institution should follow the related regulations in disposing the regulated medical items. However, the staff, they should be they should use common sense mentioned by Nigel. Okay, that when if I didn't use it with infected patient or suspected or confirmed case of COVID-19, okay, then there is a different path of disposing safely the PPE. So it is about training, education, and for the staff, it is about close monitoring and supervision of the healthcare management, okay, of the proper disposal of PPE.
Thanks a lot, Mohammed. Very clear answer. Manuel, tricky question for you. Can PPE go to general waste? What's your opinion? Well,
if the PPE is contaminated with blood, with fluids, definitely has to go to a biohazard bag. And then if you're talking about PPE, like things like lab coats and things like that, they shouldn't be washed within the facility home. I mean, some people take even their lab coats home. That shouldn't happen. There should be wash, laundry should be happening within the facility. So yes, it should be disposed in the right container, especially if it's contaminated with fluids and blood.
Thank you so much. Thanks a lot. Julia, you wanted to say something? You have your hand raised.
Yes, adding to that, it was a really strong fight, because before the pandemic, people would take lab coats and their clothes back home all the time. So we didn't have enough availability in the hospital to wash all of this clothes. So we just had them to get dressed before they would leave, and we provided them bags so they could wash their clothes separately, but do it themselves, only that treating it like biological hazard, even though now we know it's not that high of a risk, but that was a problem too during the pandemic. And it still is, because people wanted to come in and out of the ORs with their pajamas and their scrubs. So we have to do a lot of teaching and conferences and talking about the risks for the patients, for your home, and terrible examples like the use of your cell phone wherever you are and contaminating them in the hospital area. So I just wanted to add to that, Manuel.
Thanks a lot, Julia. That's a great point. And I think that's the situation that Julia described. We come across in every hospital. We need specific PPE for our iPhones these days, for our smartphones. So thanks a lot to everyone today, to our wonderful speakers. I wanted to remind you, yes, that we didn't cover all the questions that you sent to us. Thanks a lot for sending your questions. We will address most of them in our community of practice, as we always do. Most common ones, because there are like TB specific questions, etc. So thanks a lot for our audience for staying longer as usual, but I hope you enjoyed it. I hope you liked our discussion today and you found it useful. So now I say goodbye to everyone. Looking forward to seeing you during the next IFC webinar. We will send the invitation and announce the subject shortly, as we usually do in advance. And now, Natasha, did you want to say anything? So thank you, everyone, and have a great evening, day, wherever you are.
Thank you.
Yes, I do. Thank you very, very much for your participation. And I'd like to remind that we would like to hear from you. Please complete a survey on exit and let us know if you have any additional questions, if you'd like to know more, and what are the topics of our next webinars that we should cover. Please use this opportunity to talk to us. Thank you very much.